Sir.
Mr. Chairman, dear colleagues, the title of my presentation is, just a moment, please. Is non-deformed knee osteoarthritis ended up in a complete stiffness? It's a case scenario. My name is Maher Al-Assal from Asyut University, Egypt. A male patient, 50 years old, obese, with BMI equal 34, not known diabetic or hypertensive, nor any comorbidity. Presented to me with complete stiff right knee in extension. History, the primary complaint or the index complaint of osteoarthritis was osteoarthritis right knee before any intervention. No benefit from medications. PRP injected 4 months ago, followed by infection. This is the beginning of the problem. Open arthrotomy had done after failure of conservative treatment. The case ended up in pain and complete stiff right knee in extension. On examination, non-deformed knee, no range of tibiofemoral or patellofemoral range of motion, severe stiff knee in full extension. Images and lab workup had done. This is the AP and lateral views of plain X-ray, shows osteoporosis of the knee region as a whole. You hear me? With mild medial
Sir,
joint.
we hear you, sir. We hear you, sir.
With mild medial joint space reduction. This is an entire MR axial views. If we are focusing on this view above the patella, we find a lot of fibrous tissue in the suprapatellar pouch extending to both gutters, medial as well as lateral. Back again, if we're focusing on this view at the level of the patella, we find a dense fibrous tissue in this area and also to the gutter. In the sagittal view, of the MRI of this patient, we notice a dense fibrous band extending from the patellar tissue to the pre-tibial recess. This is named as patellotibial band. In arthroscopy, revealed severe fibrosis of the suprapatellar pouch and the gutters. So suprapatellar pouch is re-established first at the working room. The trapped patella is mobilized with retinacular release in addition to anterior patellotibial band. And this is the patellotibial band. Resect fibrotic masses in the intercondylar notch, the medial and lateral compartment. This is medial compartment, and the pre-tibial recess by shaver or by Weber. We can notice In this picture, the knee is completely extended and stiff, and this is after the arthroscopic release of all fibrous tissues inside. We got about 80-degree flexion. From the quadriceps, free the quadriceps from the anterior femur by a 6 millimeter osteotome until recreation a satisfactory range of motion with adding a manipulation, This is the manipulation. The manipulation increased the flexion to about 100 degrees. This is the manipulation. The take-home points, if we go to this picture, I can say the Egyptian succeeded in refloating of this giant evergreen giant ship that was wedged across the Suez Canal. The effect of PRP on this tricompartmental osteoarthritis is like a negative effect of this pushing the tractor on this giant ship to refloat it again in the normal water path. So not all studies support the use of PRP. PRP does not work for everyone. Some physicians don't recommend it at all, while others use it more liberally. If you choose a PRP, follow complete aseptic conditions. Complicated septic knee is always ended up in at best stiffness and at worst complete destruction of the joint. Thank you very much.
Thank you so much, our beloved professor, Professor Maher Al-Assal, for this very, very interesting talk. Thank you so much, sir. Now we will move to the next speaker. The next speaker will be presented by my dear friend, Professor Dr. Srinivas Kamphamti from India. Professor Srinivas will speak about, will present a case, a terrible triad of the posteromedial knee associated with ACL injury. Professor Srinivas.
Good evening, everybody. I bring greetings from India. I would like to thank the Egyptian Orthopedic Association, Benha Orthopedic Department, and Professor El Ashab in particular for the invite to present in this wonderful meeting. We're in the middle of some challenging times. My thoughts with all those who suffered and tributes to those serving during this deadly pandemic. I thought I will present an interesting case today. We have published this case recently. It's on a terrible triad of the posteromedial knee associated with ACL injury. Sorry. This is the case that we published. It's this year's JCOT. It's about a bony injury with a ramp lesion and a double meniscal injury, defunctioning the meniscus and forming a terrible triad in the knee. ACL is the most commonly injured ligament in the knee joint, and it is associated with meniscal injuries in 47 to 61% of the cases, and a ramp lesion in 9 to 17% of the cases seen during ACL reconstructions. Other ligaments may be injured. There may be bone and chondral injuries associated along with this injury. This case is a 24-year-old man who presented with instability of the right knee of 2 years duration. A 10-foot statue of Lord Ganesha, who is a popular Hindu god, fell on his knee and he sustained this injury. He's a fit and well person, and on examination of his knee, there was no effusion. Lachman was 1+, anterior drawer was 2+, pivot shift was 1+, PCL, PLC, collaterals, and meniscal signs were negatives. Range of movement was full without pain. Radiographs showed early osteoarthritic changes in the medial compartment with reduced joint space and osteophytes. There is a hint of bony injury of the tibial rim posteriorly. MRI scan confirmed the fracture of the posterior rim of the medial tibial plateau as seen in the sagittal sections, as well as there is some evidence of injury to the adjacent meniscus. In our case, the following were seen. There's a fracture of the posterior rim of the medial tibial plateau. There was a ramp lesion. There was double injury to the meniscus. The posterior medial meniscus root was avulsed. There was radial tear of the junction of the posterior horn and the body, leading to an amputation of the posterior horn of the meniscus. And that has displaced, along with the rim fracture fragments, into the ramp lesion. An arthroscopy was done. And these were the findings of arthroscopy. There was no ACL there. This was a posterior, the trans-notch view showing the posteromedial compartment. This is the medial compartment. We can see that posteriorly there's no meniscus. Again, a trans-notch view. This view is through the posteromedial portal. You can see there's a fracture of the posterior rim of the proximal tibia, along with the ramp lesion. This is again a medial compartment. You can see the posterior part of the meniscus is missing. And there is osteoarthritic changes, early OA changes within the compartment, some fibrillation. Through a posteromedial portal, the ramp was explored. We can see there's a tissue within the ramp, which looks like possible meniscus and osteochondral fragments. They're all adherent, and the morphology has changed. It was difficult to remove every piece of that, so whatever we could remove, we removed. We made another second portal into the posteromedial compartment in order to, one to hold, the other one to remove the fragments. So using a first pass device, a fiber wire was passed through the capsule, synovial capsule. Forming the ramp. Another bite was taken. And taken out through the posteromedial portal. A guide was placed to pass a guide wire coming from anterior into the posteromedial compartment where the fracture was. Over the guide wire, a tunnel was drilled using a 4 millimeter drill. The shuttle suture loop was passed through the tunnel to take the fiber wire anteriorly. So the fiber wire was taken through the tunnel anteriorly. And when we pulled from anterior, the ramp was closing up. This is a view from the posteromedial portal. We can see the ramp closing up, and we pulled on the fiber wire anterior from the anterior aspect. The meniscus was debrided, the fracture surface was debrided, and the ramp lesion closed. This is a postoperative radiograph. ACL reconstruction was done. This suture disc was holding the fiber wire from the posterior aspect, holding the capsulosynovial junction to the stitched and held to the posterior fractured surface. Ramp lesions have been classified as stable or unstable. A more anatomical classification was done by Tonert et al. The mechanism is unclear in the current literature, and treatment is to fix the unstable type of ramp lesions. Risk factors for ramp are bone marrow edema, contact injury mechanism, and concurrent lateral meniscal tear. Some other factors by Sonnery Quartet were male, age less than 30 years, revision ACL reconstruction, when side-to-side laxity is more than 6 millimeters, and in chronic ACL ruptures. Meniscal root avulsions, what we saw here was the posterior horn of the posterior root of the medial meniscus was avulsed. It belongs to type 5 of classification of root tears, according to Laprade et al. In the meniscal body tears, the tear we saw is a radial tear at the junction of the body and the posterior horn. Normally, they occur as a longitudinal tear with or without bucket handling. There was complete amputation in our case and segmental loss of the meniscus, which has not been reported before. Although bone marrow edema of posterior tibial rim has been reported in association with ramp lesions before, there was no report of fracture of the rim in association with meniscal injury and ramp lesions. So our case has implications on classifications of ramp, meniscal root, and meniscal tear types. It adds a new dimension to these injuries, tying all these injuries together. It extends severity of injury of these structures to a new level, leading to early onset of osteoarthritis. The probable forces involved are a posterior and inferior force from the femur on an anteriorly displaced tibia after the ACL is ruptured. It raises a lot of questions in managing such injuries. Multiple challenges are posed in the chronic setting, acute setting, managing meniscal loss with deficient base, repairing ramp to the bone, the role of partial meniscal allograft transplantation, and how we identify and prepare such injuries preoperatively. This case raises more questions than answers. We are not sure how much of a stable base is required for a functioning meniscus before we could consider partial meniscal transplantation. It is an interesting case for discussion for which I don't have all the answers. I would welcome inputs from esteemed faculty and audience on how to go about managing this case and similar cases in the future. Thank you very much. Take care and stay safe.
Thank you so much, Dr. Srinivas, for this very interesting case. Thank you so much, sir. Now we have to move to the next speaker, Professor Hussam Al-Shafei from Alexandria University, Egypt. Professor Hussam will speak about open knee dislocation.
مساء الخير عليكم جميعا. انا الحقيقه بشكر الدكتور محمد الاشهب على دعوتي ليا ان انا اقول البرزنتيشن ده من ضمن كبار اساتذه جراحه العظام في مصر والعالم، وان شاء الله يكون يوم جميل في 56 برزنتيشن. دي حاجه جميله جدا صراحه. My presentation about open fracture dislocation of the knee. This kind of injury, and I'm quite sure it is very rare in orthopedic surgeon, and I think each one of us may have not seen a case of open fracture dislocation of the knee in his whole career. الحالة دي أنا شفتها قبل ما أقول الحالة نفسها. دول من الحالات ال very rare open peroneal hip dislocation, and I saw them in 1986 في آخر سنين ليا أنا وأنا نايب في الحضر الجامعي. والحقيقه دولت كانوا من الرير، ما لقيتش في الليتريتشرز لغايه النهارده حالات زيهم، والحقيقه منشورين ولهم سايتيشن موجودين في الليتريتشرز. This patient presented to me a 17 years old male, sustained an injury motorbike accident. وبعدين came to the hospital. They called me to see this patient, and this is the situation as you see here. هو عنده head injury وكان دراوزي شوية، لكن حقيقة ما كانش عنده severe head injuries. Neurologically free، ما كانش عنده أي neurological deficit even distal in the affected limb. Vascularity was okay. بس طبعا احنا ده open brain hip dislocation، واحنا عارفين كلنا ان في about 30% of patients may have an intimal injury of the popliteal vessels. المهم البيشنت جه المستشفى، اتعمل له primary irrigation وضغطت الوند بدريسنج، والرجل was immobilized in a brace. طبعا قبل ما ندخل اوضه العمليات وديسايد وات وي جونا دو، الحقيقه لازم يكون طبعا هو كان عنده هيد انجري والانستيزيا رفض انه نيمه في in the night of the accident. We waited until next day. والحقيقه كان احسن طبعا عشان نقدر نعمل CT angio عشان نشوف ال distal circulations of the affected limb. As we said before, now 30% of patients may have an intimal tears of the popliteal vessels. المهم عمل CT angio طلع كويس، ما كانش فيه اي حاجه. وبدانا نفكر هنعمل له ايه العيان next day. وطبعا انتوا فاكرين طبعا كلنا واحنا في بدايه حياتنا كان الرول اوف 6 hour rule for open fractures، ان لازم خلال 6 ساعات احنا ندخل العيان نعمل له debridement و primary management. الكلام ده مش مظبوط قوي في recent literatures. المهم عندنا ان احنا to prepare the patient properly and plan properly. ده associated injuries مع العيان اللي احنا شفناه في الصورة الأولانية خالص. وعنده fracture distal third femur closely fracture، وعنده fracture osteochondral fractures of the medial femoral condyle و split fracture of the medial femoral condyle. The CT showing the previous injuries which I've said. هنا شايفين هنا ده ال osteochondral fractures. هي عامله زي الهفه بس مش is not complete. وده ال vertical fracture بتاع الميديال femoral condyle. وده زي ما احنا شايفين الانجرز الموجوده حاليا اختصرناها: closed fracture distal third femur, open vertical split fracture medial condyle of the femur, osteochondral fracture of the medial femoral condyle. وعندي posterior medial corner injuries of the كل posterior medial corner has been disrupted, medial ligament, posterior oblique ligaments, even حتى ال medial head of the gastrocnemius has been destroyed, been avulsed from its place. وعندي avulsion of the PCL from the femoral attachment وtorn ACL. اللاترال collateral الحاجة الوحيدة اللي كانت intact موجودة في العيان. Procedures احنا خدناها الثياترز. أول حاجة عملنا debridement, proper irrigation, massive irrigation using pulse lavage, and then we decided to fix the femur first with a distal femoral plate. وبعدين بعد ما خلصنا الفيمر بدأنا نعمل reconstructive surgery of the involved ligaments. ولastly skin problem of skin coverage. هنا الصورة بتاعت العيان اتعمل له distal femoral plate و interfragmentary screws to fix the vertical split of the medial femoral condyle. After that we look after the interarticular pathology. احنا قلنا العيان عنده osteochondral fracture of the femoral condyle. We fixed that with the 4 Herbst screws. وكانت fixation reasonable. وبعدين بعد كده عملت reattachment of the avulsed femoral attachment of the PCL. عملناه بفايبر تيب. الفايبر تيب very strong. وعملنا sutures وعملنا tunnel في الفيمر كوندايل وخرج بره هنا التانل من السوتشرز بتاعتنا. وهي حطيناها حوالين السكرو and washer to reduce the cost. However, the implant's cost was very high. وده كان الفيكسيشن بتاع البي سي ال وكان very good. حقيقة كان كويس قوي. And then we looked to the posterior corner of the knee and the fixation of the pull-out sutures of the PCL avulsed from the feet. And then we looked for the medial collateral ligaments MCL and the posterior oblique ligaments, ودول احتاجوا ان انا استخدم 3 anchors fixation to fix this torn ligaments. وده في الاخر ده البوزيشن after surgery of fixation of the bony and interarticular sac. We didn't do anything for the ACL هي كان completely torn وما كانش في اي possibility ان انا اعمل له repair. Lastly, we got the problem of the skin coverage. والحقيقة بعد ما عملنا irrigation السكين حاول my colleagues my assistant was very clever ان هو approximate او يضيق المكان شوية of the wound وبعد كده حطينا vacuum. الحقيقة vacuum is very good وحطيناه decide to do the vacuum over this. الموجود الأبيض ده عبارة عن vancomycin powder. وده الاكس راي بوست اوبراتيفلي احنا شايفين الفيكسيشن موجود وادي الهيربر سكرو تو فيكس ذا اوستيوكوندر فراجمنتس والانكرز تو فيكس ذا medial and posterior structures of the knee. Skin coverage, whether to do a primary skin coverage or medial head gastrocnemius flap or fasciocutaneous flap. الحقيقة احنا عملنا بس just approximation خفيف كده ده واستخدمنا الفاكيوم ده after first vacuum وبعدين دي الwound after second vacuum وده بعد second vacuum third vacuum قدرنا ان احنا نعمل secondary sutures direct closure. والحقيقة كانت زي ما احنا شايفين ما كانش فيه great tensions over the wound و closed primarily. ده الاكس راي after 4 months fractures healed. ده احنا شايفين في الصورة all fractures was healed. وده العيان 4 months post-operative. الحقيقة كان fully weight bearing after 5-6 months and flexion deformity with range of motion from 30 to 90 degrees. He was intensively sent to physiotherapy.
دوسي يا جو ما تخافش. احنا كده بقالنا قد ايه يا جو؟ 4 شهور. تمام يلا دوسي يا جو ما تخافش. ما تخليهاش محنية. خلي بداية الخطوة من كعب رجلك. يعني دوس بالكعب.
ده range of motion at 8 months. والعين كان بيعمل الفيزيوثيرابي كان very well dedicated للفيزيوثيرابي instructions. وده العيان after 1 year.
يجي روح بقى.
You see العيان عنده fully weight bearing. هي
لف كده لف يا جو تعالى.
stable knee. He doesn't have any
side
of instability. عنده range of motion as you see from the side. He had a full knee extension وعنده flexion up to 120 degrees. He was able to squat, jumping. He's very good. Patient's status snap, fractures healed, no articular nice articular reconstructions, healed PCL, healed posterior corner, successful secondary closure, range of motion from 0 to 120. Still have ACL deficiency, however he doesn't have any giving way complaints. Patient's expectation and the family, they required for range of motions and he wanted back to play football. What do you suggest as a next step of management الحقيقة عشان خاطر العيان عنده expectation عالي جدا انه يلعب كورة تاني و back to normal life sports life. Expectation is the root of all heartache. William Shakespeare. Thank you very much.
So much, Professor Hussam Shafii, for this very interesting talk. Thank you so much, sir. Now we will move to the next speaker. The next speaker will be our dear professor, Professor Saeed Al-Thani from United Arab Emirates, the president of the United Arab Emirates Orthopedic Society. Welcome, sir. You are very welcome. Professor Saeed.
Thank you very much. I just want to correct one thing. I am the former president of the Emirates Orthopedic Society. My colleague, Dr. Ali Al-Suwaidi, is the chair. So I want to thank you again for the invitation. It's always a pleasure to give presentation and share knowledge with you all. I'll try to make it simple. You can see my presentation?
Yes, we can see it, sir. It's
okay, good. So when we talk about multiligament, it is always talking about the dilemma of where to go, where to start, conservative versus operative, timing of surgery, repair versus reconstruction, allograft versus autograft, partial versus total, and immediate versus delay. So these are the questions always as a surgeon we need to look and to see what to do. What I'm presenting here, this is a 22 years old male who was involved in car accident. He worked as a firefighter and he was involved in this. So he came to one of the trauma centers and he presented with this image, which you can see the knee is almost fully dislocated. And he had multiple images and MRI. This is the MRI can show there's completely rupture of the medial BFL and MCL. If you look here, this video of the MRI will show as steps, no ACL and no BCL, with the posterior lateral corner as well injured. So this is pictures of the images from the MRI that's done at the time of the injury, and it's just confirmed it's multi-ligament injury, which is not what we see every day. It is what we get when we involve in a car accident or a high energy injury. So this patient presented to my clinic 6 weeks after. He was treated conservatively with he has a cut wound around the knee. They suture it and they treat him with the brace, and he presented to me with stiff knee and range of motion 20 to 60. In these cases, we have to know that we cannot operate. Doing any surgery with this knee is a crime. What we need to do is to improve the range of motion. So I sent him to the physiotherapy, and here's lucky his father was a football player, so we take him to the club also, where he had every day stretching and manipulation of his knees. And 6 weeks later, he was having almost full range of motion. And at that time, we planned to do the surgery for him. So this patient had, in summary, the list is, he has ACL, he has BCL, he has posterior lateral corner, he has a avulsed MCL, and medial patellofemoral ligament. So almost like five ligaments is torn here, and we need to know where we start. Should we do it all at once, or should we do it stage-wise? I think you can do it stage-wise if you focus into what you want to do, depends on the situation you have. Unfortunately, the insurance will not allow it. So I have to do it all at once. And it's been documented and done in different places, and I've done it before to do it all at once. You just need to coordinate the time. And you have to understand, this is his examination. You can see his pivoting there. And it's on anterior drawer. And if you look at here, you can see the lateral corner is totally loose. The foot is way off. So when we try to do an ACL or multi-ligament, we have to plan our tunnels. Otherwise, we might have a tunnels convergence where we open to each other. So you have to plan and meticulously draw your tunnels on a paper or on a model. You know, when you do multiple ligaments, there is a lot of things goes around in the knee. Better to draw your plan on the screen or on the board in the OR, and you discuss this with your team, the steps of what you're doing. Otherwise, they will not follow, and they will make your life miserable through the case. So you need to make it stepwise, so they know each time what they will do and how they make you happy, and how make this procedure smooth as possible. This is all to do with the pre-operative plan. And then when you go to the posterior lateral corner, you have to do the posterior lateral dissection first. Why we need to do the extra-articular first? If the knee is swelled from the arthroscopy, from the extraposition, it will be very difficult to identify the common peroneal nerve and other small structures. So you need to do your dissection, identify your common peroneal, identify your tunnel, make your tunnel ready for, this is for the fibular ligament, and then this is for the popliteus tunnel through the tibia, and that's for the fixation of the femur. So you know where you're gonna get your suture passer and which ones will take each ligament. Because easily with these, you can get things goes wrong. And when you do your extra-articular, go and do your arthroscopic tunnels, do your ACL, PCL, and prepare all these tunnels and ready to execute. And once you finish your tunnels, then you need to start with the sequence of fixation. So here, you can see this is after we fix it.
وابتدت التفصيلات بتاعت النور والميه والمجاري كله شغال على الطريق.
That's the MCL is good. Is come to all the ligament. Are you okay?
Yeah, we can hear you.
Okay, so this patient supposed to come to me. He was doing well. He was we put him in the extensive physiotherapy after the surgery, and he unfortunately, in his 1-year anniversary, he went to play football and he injured his MCL. The MCL, we did repair it and augment it with internal brace, but with his football injury, that damaged it completely. And because, and you can see here, it's open up laterally. And even it gives an impression that the ACL might be loose as well with the anterior drawer. So we went and we did an inverted V-shaped repair for the MCL using allograft. We couldn't take any more autograft because we used more for his 5 ligament reconstruction in the year before. So we fixed in the inverted V shape where we control the MCL anterior and posterior MCL as well. And this is his knee after that. You can see the MCL is intact, and you will see soon the anterior drawer is also solid, just using MCL without touching his ACL. So the moral of this case is multi-ligament knee injury is a complex problem, require preoperative planning. Tenon position, all the tenon should be placed on an anatomical footprint to avoid tenon convergence. Sometimes you can use the acorn lever to smoothen the tenon edge for the graft passage. Fixation of the ligament should be PCL tension first, followed by PLC, then ACL, and finally MCL when it comes to the sequence of fixating the ligaments. Thank you.
Thank you so much, Professor Saeed Al-Thani, for this very interesting case and very interesting talk. Now we have to move to the last speaker in this marvelous session, will be Professor Mahmoud Hafiz, 6th of October University. Professor Mahmoud will speak about achondroplasia with severe knee osteoarthritis and valgus. Professor Mahmoud.
This case here is achondroplasia, which is something that you don't see quite often. I can tell you that I had no previous experience with cases like this before. So I had this patient who was a hospital staff. She's 50-year-old, she's female dwarf. She did this achondroplasia and diagnosed with this for a long time. She had bilateral osteotomy 20 years ago. So we were at the time of presentation, she had painful knees. Luckily, she had more pain on the left side, which is less deformed than the right side. So I had to deal with the less difficult one first. And this was good for me because so was this painful knees and more on the left side, and she lost quality of life. She was taking regular analgesia, she was walking indoors, and she started getting off work, and her conservative treatment was failed. So we had no options apart from going for intervention. So on presentation, her height was 120 centimeters, and the length for the whole lower limb, thigh and leg, was only 40 centimeters. We know from anatomy that the femur only alone is about 50 centimeters. So here is a 40 centimeter for femur and tibia and foot. She had flexion, contraction. She had also valgus deformities more on the right side. This was partially correctable. Her range of motion was 15 to 90 on the left and 20 to 70 on the right. So apart from the stiffness, also she got this flexion deformity up to 20 degrees. This is her radiographs. It looks scary on the right side with severe valgus and huge deformities bilaterally, as you can see. And the deformities are not just intra-articular, they are intra and extra-articular. You got bone defects, you got osteopenia, you got multiple exostosis, and you can see this obviously on the EP and lateral views. What to offer this patient? So here are the questions. The first question to you, do you continue on conservative treatment or would you consider doing osteotomy first? Or do you like to do bilateral simultaneous TKA for this patient? Or you want to do unilateral, but starting first with the left side, or you start with the right side, or ask the expert. I can just go to the next question. And here, how to correct these deformities? You can look at the deformities, you can look at the lines that I drew here with the red, blue, and yellow, and with the start voting here. What do? Do you do a TKR and osteotomy later on? Osteotomy and TKR later on, sorry, or do you do osteotomy and TKR in one go, or TKR using extramedullary or intramedullary or navigation or others? Okay, so with the next one, expected difficulty in this case, you could have actually multiple answers, and that's expected in a difficult case like this. Is it the anatomy and exposure? Is it the conventional instrumentation here that is a problem for you? Or is it the intra and the extramedullary guides? Or is it the proper sizing of implants, the bone defects, or the soft tissue balance? So we can go for the next question. What type of implants are you going to use? Are you going to start a primary TKA using cruciate retaining, or primary TKA using a PS, primary TKA with other CCK, hinged knee, or just to go funny and ask the sales rep? So with the further imaging, actually, we did a CT scan for this patient because we decided to use patient-specific instrumentation, which I use it almost routinely, and for this case proved to be very useful. So with a patient-specific instrumentation, we have either to do imaging, CT scan or MRI. We use CT scan, and with the CT scan, it's bilateral here. We do also a scanogram from the top to bottom. You can see the deformities here on APL, lateral, well, in the 3 planes. You can see this is a scanogram with the long leg here. You can see the AP and the lateral. And as you expect, with the scanogram and the patient is lying down on the CT machine, the deformity is going to be less than when we were standing. So the valgus here was lying on the left side, but in fact, with the standing was 15 degrees. Okay. So we started with the left side first, which was the less difficult, and also it was it has more pain and more symptoms. So we have to address this first. So doing that with the planning, we got a lot of surprises. One of it is that the size of the tibia is not matching the femur. With some implants, you can have maybe one size above or below. Some other implants you could have matching for all sizes. So in this case, this helped us with the planning and choosing of implant. And the other thing is that the smallest size tibia for the implant that we decided to use was still bigger, as you can see with the overhang here on the this view on the left side. So we decided to change the implant company to get a smaller size tibia, also to fit a bigger size femur. So with the PSI planning, you can see the position of the patient-specific instrument on the bone before surgery. You can see here is almost like touching the bone, and that's because of the deformities. Normally, we have a gap between that distal part of the femur and the template, and you can see where you position the guide. It has to go in one fixed position. The planning for the other side, the right side, as you can see here, there's more valgus deformity, which was 25 when the patient is standing and 16 when the patient is lying down. And we're actually running a study to compare between a scanogram and standing mechanical axis to see the difference between the two. You can see here also the intramedullary angle, which is 6.4. See here the planning for the right side, you can see is more deformities and similar problems also as we see in the left side, in addition to the more deformities. You can see the PSI planning and the cutting the blocks. With this femoral cutting the block, you can do all the cuts from that block, and also for the tibia, you can do the cut, you can do the stem and keel. Here was the position of the implant on the right knee, and that's all before surgery. So you can change anything that you find it is not right. Okay, whatever you bought here in the implant, you will never get something like normal, but at least your aim is to maintain the alignment and get also the proper soft tissue balance. So with regarding expected difficulties, actually we had all the difficulties listed there. The complex exposure, we couldn't even, like the routine medial parapatellar that every surgeon will do easily, here was even difficult. The abnormal anatomy that we see in every part of the knee, definitely you couldn't use extramedullary or intramedullary because of the extra and also intramedullary deformities. You have very small tibia compared to a large femur due to conventional instrumentation difficulties. They have bone defects and also soft tissue balance. You can see here with the femoral preparation, with the PSI, we had to be, we were in doubt at a time, and we measured this also with the conventional instrumentation, and eventually we found that the guide and the computer was right. Okay, but the knee, which looks very funny, make every surgeon will doubt every step that he does during surgery. Here with the tibial preparation, this was extremely difficult. If you look at the picture here on the left-hand side, and you see the position of the tibial implant, when we used the conventional instrument, the tibia was too short to get even the lowest part of that guide. Okay, with the soft tissue balance here, with regards to the left knee, it was easier than the right side, but still we had to do almost all the steps for a bulgus correction with the soft tissue, removing osteophytes, dealing with the IT band, and posterolateral capsule. We did also a pie crusting and a sliding of slitting. With the right knee, we had to do something extra here. The medial ligament, there was a very slight laxity, which we dealt with just reinforcement, but it was stable with this. It was just, I know that this does not normally work, but we did not have, even if we didn't do it, there was no instability intraoperatively. So we also put the patient in a knee brace for 6 weeks, just only for the right side to be on the safe side. This case was not done bilateral simultaneous. As I mentioned, we did the left side 4 years ago, and the left side was a year later, and our implant choice was a PS knee. So we did not use CCK for many reasons. One of them is that the bone was not going to take a stem, and there was no requirement intraoperatively. We had it standby, but we did not require this. This is a post-operative photographs, and also we have a video. I don't know if you have time for this, but this is a 6 weeks post-operative. You can see the patients lying down and standing. Here is a video. If you can work the video on the top view. The follow-up is actually, so it's the 4 years now for the left side, which was done first, and 3 years now for the right side. Here, and thank you. I look forward to your questions.
Thank you so much, Professor Mahmoud, for this very interesting talk. Thank you so much, sir. Our dear panelists, we have 10 minutes for discussion with our distinguished guest speakers. If any questions to the guest speakers, please.
Yes.
السلام عليكم دكتور محمد.
تفضل دكتور ميربي. تفضل استاذ.
I would like to tell Professor Hissam Shafi, you have done a very good job. I never see in my career such a case, so I am very happy.
Thank you. Thank you very much.
The question to Dr. Mahmoud Hafiz.
Yes.
You didn't mention anything about the range of motion.
Okay.
Post-operative.
Yes, I think I had in the last slide, there was a video, and that video showed the range of motion. She had full extension. So the range of motion was from 0 to at least 100. And that's showed in the video. Unfortunately, the video was not in the recording, just to save time, because the recording was just about 10 minutes.
Thank you.
Okay.
Professor Wael Nassar.
Assalamu alaikum, Dr. Muhammad. Thank you for all colleagues and for Dr. Muhammad for the invitation. My question also is for Professor Dr. Hassam Al-Shafi'i. You know, sir, that standard teaching that polytrauma patients with skin and soft tissue problem and with an open fracture dislocation knee, the standard teaching in احنا for damage control with an external fixator, spanning fixator. What in this case in particular makes you to take the risk of putting internal fixation from the start and going away from the classic guidelines?
هي بس هي مش classic guidelines، ولكن أنا حسيت إن ده if I fix the fracture femur and reduce the knee and stabilize the ligaments primarily, especially in the wound, ما كانش very contaminated. When I spend a lot of time during the surgery to do proper irrigation of the wound, and maybe not classic, ولكن أنا I don't want to say that I take the risk, ولكن أنا at that time I decided to do this, and I was happy at the end of the surgery and I got stabilized and knee reduced very well. والأمور كويس الحقيقة. وأنا شايف إن الريزلت أعتقد إنها at the end of the day was very good.
هو طبعا تسلم ايد حضرتك والريزلتس جميله جدا، بس انا بالظبط احنا خايفين المسج تبقى كوندكتد رونجلي، ان الناس تعمل زي حضرتك ويحصل مشاكل.
اقول لك بس هو الاوبن ني ديسلوكيشن how frequent people see this case. انا ما شفت دي حاله واحده شفتها in my 35 years Korea. انا اعتقد يمكن ما فيش حد من الزملاء شاف حاله زي كده بالمنظر ده يعني.
Professor Mahmoud from Iraq. Yes. Professor Mahmoud.
Yes.
Welcome,
thank
sir.
you very much.
Welcome,
thank you. How are you? Actually, I have two questions. One question to Dr. Maher, the second to Muhammad Hafir. Dr. Maher, actually, you show us it is a soft tissue ankylosing, and you're going to scope. My question, there is any bony ankylosing with this associated with soft tissue? And if there is bony ankylosing, you going to open or you're still working arthroscopic?
Well, thank you for this question. All of the deformity was related in the case I presented is related to the soft tissue fibrous masses in all the compartment of the knee. I like to do these cases arthroscopically, but I think open is more easier, and you can get the same or near the same results.
Okay, thank
there
you.
Is no
the
bony,
second question.
Bony ankylosing. There is no bony ankylosing in this case.
Okay, thank you very much. If you allow me for second question,
yes,
Dr.
sir.
Muhammad Hafiz.
Yes, sir.
I showed your X-ray, post-operative X-ray. There is patella baja. How you say this? There is flexion and extension. If you observe it, if I am right, there is patella baja. You know this will limit it with the flexion extension.
Professor Mahmoud Hafiz.
Do you hear me? Yes.
Sorry.
Mahmoud Hafiz.
Professor Mahmoud Hafiz, you hear us, sir?
Yes. Sorry again. Could you just repeat the question? I thought it is for Professor Maher. I'm sorry.
Sorry, Professor.
Go ahead again.
I saw your post-operative X-ray. Actually, there is patella baja, and this is there is shortening of the patellar tendon. Okay. This is not limited the flexion and extension.
No, actually, the range of motion was even better than we expected. I mean, this patient is not just achondroplasia; she was obese. So you would expect that the flexion will not get to 90, but she was beyond 90 degree of flexion. She had full extension. She's been back to work. She's a hospital staff, and she's been back to work. And at the last follow-up, as I mentioned, 4 years and 3 years, she's maintaining the good range of motion. As I mentioned in the post-operative X-ray, that in cases like this, you will never get into a perfect position because that's impossible. unless you're going to change the whole bone and make it normal. So if you look at the CT scan images and also the X-rays, you will see that the posterior opposite of the femur is huge. You know, like the whole condyles are shifted like posteriorly, and also shifted. There's a mediolateral also translation. So it's impossible to position the implant, and also with the patella. And in cases like this, don't aim for perfection. Don't play too much. Just ask yourself, what is the aim? I want this patient to stand, walk, get good range, reasonable range of motion, 90 degree or just beyond this, but don't expect more than that to get good X-ray. So my advice for you is that never aim for perfect X-ray, but aim for good function and survival of the implants.
Thank you, sir.
Thank you very much.
Ahmed Al-Pashtra from Yemen has a question. Professor Ahmed.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته. Welcome, sir.
نشكر الأستاذ ماهر على الحالة المميزة والرسالة الهامة لتجنب مضاعفات خلال الحقن. وسؤالنا about physiotherapy. When start physiotherapy after septic arthritis? Because physiotherapy is most important in management on all stage of osteoarthritis and after septic arthritis. First question. Second question about for Dr. Mahmoud Hafiz about achondroplasia. What about ligament laxity in this achondroplasia? What about ligament laxity? Why not hanging total knee arthroplasty? Thank you. This is two questions. First for Dr. Professor Maher Al-Assal about physiotherapy.
Well,
second
thank
for
you.
Dr.
Thank you for this question. The patient consumed every conservative treatment before done this arthroscopic lysis. After doing open arthrotomy somewhere, the limb was immobilized in complete extension. So he presented to me with complete extension. And I would like to tell you something that infection is a very major leading factor in progression of fibrosis, infection, the pathology. So there is no way to do anything except arthrolysis, whether open or arthroscopic. And the physiotherapy after that. And the physiotherapy after that.
Must be start before and after septic arthritis, after 2 months or 3 months start physiotherapy. When start then? When start physiotherapy after septic arthritis? يعني متى نبدأ الفيزيوثيرابي after septic arthritis? يعني after 1 month, after 2 months.
The index complaint of the patient was osteoarthritis and a pain, but the range of motion was normal. The physiotherapy in this situation just to strengthening exercises for the quadriceps as well as the hamstring, but the range of motion was very well.
Before injection.
Yeah. After infection, he got the infection. After the injection, he got infection. And this is the starting of the bad history of this patient.
Thank you.
Yes. Regarding my question about soft tissue and using a hinged knee. For this particular case, first of all, is that the patient-specific instrumentation does not help much with the soft tissue balancing. So this is something that is left to the surgeon. With regards to the hinged knee, we planned to do either CCK or hinged knee, and thanks God that I did not resort to one of them, because there's going to be a great difficulty putting a stem in a case like this because of the huge deformity in the femur and in the tibia. You can see like the femoral condyles are translated. So whenever you get any intramedullary, you will never get it right. And the same also for the tibia. So even the smallest stem for a primary knee that we use, like the stem for the tibia, we had to do a lot of planning in order to make sure that the stem is not going to break one of the cortices. And if you look at the post-operative X-ray, I can get the images back if you want. You can see that the stem of the tibia and the keel are just close, very close to the cortices. So it was impossible to use hinged knee, very difficult to use CCK or any long knee. So or any knees with stems. Even a primary knee with stems going to be difficult. Even if you use that a tummy or a short stem, it's going to be difficult. So the plan was really to preserve the soft tissue as much as we can. I was lucky in this case because I did the left knee first, which was less deformed. So this gave me some idea on how this knee is bad. So when I did the right, I was, expecting the difficulties with the soft tissue. For the left, we didn't do much soft tissue release or playing. There was a valgus. We did a release laterally, okay? And I found that the medial ligament was also attenuated. So I was extremely careful with that attenuation of the medial ligament, okay? The same when we did the other side, that we were very careful. We did the release as described, especially by white side techniques, and we were very careful not to damage the soft tissue, and we had to do some little augmentation on the right side, but this was fine intraoperatively. Only for the right side, we had to put the patient in a splint just to be careful that she could have any twisting post-operatively. So just we put her in a splint for 6 weeks, but we didn't do this for left side. And it went very well.
Thank you so much, sir. Finally, at the end of this session, I would like to thank all our distinguished, eminent guest speakers and our dear panelists for this marvelous session, discussing all the topics of the knee problems. Now we have to move to the fourth